causes of connective tissue diseases are many, and they often work together rather than in isolation. Genetic predisposition. Genes set the stage. They don't guarantee disease, but they load the gun. Environmental and immune factors pull the trigger. Certain HLA associations are important. HLA-DR2 and DR3 are linked with systemic lupus erythematosus. HLA-B8 is associated with Sjogren's syndrome and myasthenia gravis. Family history also matters. A parent or sibling with autoimmune disease increases risk due to shared genetic variants. For example, a young woman with a mother who has lupus may carry HLA-DR3 and develop lupus after a viral infection or hormonal shift. Autoimmunity or loss of self-tolerance. The immune system mistakes self for non-self, leading to chronic inflammation and tissue damage. Autoantibodies play a central role. ANA, the anti-nuclear antibody, is nonspecific but common in connective tissue diseases. Anti-dsDNA and anti-SM are highly specific for lupus. Anti-SCL70 is seen in systemic sclerosis. Anti-U1RNP is a hallmark of mixed connective tissue disease. The mechanism is the breakdown of central or peripheral tolerance, which allows autoreactive T and B cells to survive and produce autoantibodies. For example, in lupus, anti-dsDNA antibodies form immune complexes that deposit in kidneys, leading to lupus nephritis. Environmental triggers. External exposures can initiate or worsen immune dysregulation. Viral infections like Epstein-Barr virus are linked to lupus and multiple sclerosis. Parvovirus B19 can mimic lupus or trigger rheumatoid-like symptoms. Cytomegalovirus has been implicated in vasculitis. Drugs such as hydralazine, procainamide, and isoniazid can cause drug-induced lupus, usually milder and reversible. Chemicals also play a role. Silica dust is associated with systemic sclerosis, and solvents have been linked to autoimmune myositis. For example, a factory worker exposed to silica may develop skin tightening and Raynaud's, classic features of systemic sclerosis. Hormonal factors. Hormones modulate immune responses, and estrogen tends to enhance humoral immunity. This explains the strong female predominance. Lupus affects women 9-to-1 compared to men, especially during reproductive years. Estrogen promotes B-cell survival and antibody production. Pregnancy adds another layer, as it can flare diseases like lupus, but sometimes improve rheumatoid arthritis due to immune modulation. For example, a woman with stable lupus may experience a flare during pregnancy because of hormonal shifts. Environmental stressors. Stressors like ultraviolet light and smoking can directly damage tissues or alter immune responses. Ultraviolet light causes keratinocyte apoptosis, releasing nuclear antigens that are then targeted by autoantibodies, leading to lupus flares. Smoking increases risk of rheumatoid arthritis and systemic sclerosis, partly by altering protein citrullination and creating neoantigens. Cold exposure is another trigger, as it causes vasospasm of digital arteries, leading to Raynaud's phenomenon. For example, a lupus patient sunbathing without protection may develop a malar rash and joint pain within days. Epigenetics and molecular mimicry. These are subtle but powerful forces shaping immunity. Epigenetic changes like DNA methylation can silence regulatory genes and cause loss of tolerance. Molecular mimicry happens when pathogens express antigens resembling host proteins, leading to cross-reactivity. A classic example is streptococcal M protein mimicking cardiac myosin, resulting in rheumatic fever. Epstein-Barr virus nuclear antigens resemble self-antigens and can trigger autoimmunity in genetically predisposed individuals. So overall, connective tissue diseases arise from a multifactorial web. Genetics, autoimmunity, environmental triggers, hormones, stressors, and epigenetic mechanisms all play their part.